Today's discussion is carcinoma of the stomach or adenocarcinoma of the stomach. Carcinoma of the stomach or stomach cancer is a very common disease. In fact, it is the fifth most commonly reported case of cancer in the world. I shall first discuss a short case history to demonstrate to you the presenting features of this important or major disease. Okay, the patient is a 70-year-old gentleman, a lorry driver by profession. He presented with loss of appetite and loss of weight with generalized lethargy for 2 months. The patient had loss of appetite for the last 2 months, and this loss of appetite was severe and affected all types of food. There was no vomiting or difficulty in swallowing, but he found it easier to consume semi-solid food. He had upper abdominal discomfort and fullness after meals. The patient also had loss of weight, about 10 kilograms in the last 2 months. He says he has lost from 55 to 45 kilograms in these 2 months. He has post-meal nausea, early satiety, lethargy, and reduced effort tolerance. He says he feels tired and lethargy and developed shortness of breath on exertion, which was aggravated by walking or work and relieved by rest or sitting. This had forced him to stop working for the last 1 month. There is no history of vomiting, abdominal pain, fever, heartburn, or altered bowel movements. On physical examination, the patient looked cachectic. However, he was alert and lying comfortably on one pillow in the semi-recumbent position. He was pale but not jaundiced. His vital signs were normal, and there were no cervical lymph nodes enlarged, no clubbing or peripheral cyanosis, and no pedal edema. The abdomen was not distended. There were no surgical scars or visible peristalsis. The umbilicus was centrally located and inverted. A vague mass was palpable around the lower epigastric and right hypochondrial regions. It was mobile and non-tender. It was dull on percussion and moves with respiration. Succussion splash and shifting dullness were negative. So in summary, we have a patient who is a 70-year-old gentleman who is a lorry driver who presented with vague complaints of loss of appetite, loss of weight, and generalized lethargy for 2 months. On examination, he was pale and cachectic, but not jaundiced, and there were no cervical lymph adenopathy. There was a vague mass in the epigastric region, which was firm, mobile, and non-tender. There is no evidence of ascites, liver, spleen not palpable. So this is the provisional diagnosis for this patient will be carcinoma of the stomach. Carcinoma of the stomach. Carcinoma of the stomach or cancer of the stomach is not a very uncommon carcinoma. It affects Asians more. It is more common, geographically more common in Japan and some parts of Asia, especially China. The age group most susceptible to this cancer is the elderly patients, average age of 65 years. Men are more commonly affected than women. As for the causative or etiological factors, Helicobacter pylori infection associated with gastritis, gastric atrophy, and intestinal metaplasia has become the most very common predisposing factor for this condition. And in these cases of Helicobacter causes, the carcinoma occurs at the body and distal stomach. Other risk factors are pernicious anemia, gastric polyps, previous peptic ulcer drainage procedures, example, Billroth 2 gastrectomy or vagotomy and drainage. What are the special peculiar risk factors for carcinoma of the stomach? Tobacco smoking and industrial dust ingestion, diet, pickled vegetables, salted fish, excessive dietary salt, smoked meat are considered to be high risk for the development of cancer stomach. Smoked meat, especially smoked salmon, is supposed to be a very important cause in Japan. Diet, fruits and vegetables rich in vitamin C give some degree of protective effect to developing cancer of the stomach. Now, the histopathology of gastric cancer. What are the types? What are the different histological types that you have? First, you have adenocarcinoma, which is the most common. 90 to 95% of all gastric cancers are adenocarcinoma. And this, according to the histological variety, it can be tubular, papillary, mucinous or signet ring cell, and undifferentiated lesions. Younger patients tend to have a more aggressive histological type of cancer. Second, lymphomas. Second most common gastric cancer after adenocarcinoma. The others will be gastrointestinal stromal tumor or GIST, which account for 2%, carcinoid tumor 1%, adenoacanthomas 1%, and squamous cell carcinoma 1%. Early gastric cancer or EGC. In this group of cancers, which are very early mucosal lesions, there are no specific features to definitively distinguish it symptomatically from benign dysplasia. So in other words, they are usually clinically unable to be differentiated from benign dyspepsia. They may have vague epigastric pain, they radiate to the back, initially intermittent, later becomes more constant. Gastric anti-secretory drugs, especially PPI agents, may even improve the symptoms of gastric cancer. Only liberal endoscopic screening of dyspepsia will detect early gastric cancer. And this is what is done in Japan to improve the treatment outcome. As for advanced gastric cancer, the clinical features are much more direct. Early satiety, bloating, distension, and vomiting. This early satiety is a very significant symptom in these patients. So elderly patients coming with the bloating and early satiety always must try to arrange to do a scope for him. The tumor may bleed, and that causes iron deficiency anemia. It's another common symptom of anemia. Symptoms of anemia: pallor, breathlessness, and feeling tired. Epigastric mass and hepatomegaly, weight loss and pain at night. Features of gastric outlet obstruction such as dysphagia, epigastric fullness, vomiting, especially in pre-pyloric tumors, gastric outlet obstruction. Alkalosis is usually less pronounced or absent due to relative hypochlorhydria in the stomach due to diffuse gastritis, concomitant presence of diffuse gastritis in these patients. Late signs will include metastasis to Burkhouse node in the left supraclavicular fossa, which is known as the Troisier sign, and unexplained weight loss, pallor, and lethargy. In an elderly patient, always we must think of
carcinoma of the stomach, and he must be investigated with the OGDS. Non-metastatic effects of malignancy. Sometimes patient can present with that paraneoplastic syndromes, thrombophlebitis, which is known as Trousseau syndrome, deep vein thrombosis due to the effect of tumor on thrombosis and hemostatic mechanisms. These are all rare but possible associated presenting symptoms in the minority of patients. In most countries, including Japan, carcinoma occur at the body and distal stomach, more commonly than proximal stomach. Proximal gastric cancer apparently not associated with H. pylori infection, in contrast with carcinoma of the body and distal stomach. What are the investigations that must be done in patients suspected to have gastric cancer? Most important and the most effective is endoscopy and biopsy. Previously, this endoscopy and biopsy has replaced the previously popular chest X-ray and double contrast barium mirror X-ray. Second investigation, contrast enhanced computer tomography or CECT of the thorax, abdomen and pelvis. This is also very important for the staging of the disease. Endoluminal or endoscopic ultrasound and laparoscopic ultrasound are also done in most cases before operation in order to ensure there's no secondaries in the abdomen. In some patients, you may want to do a post-emission tomography, PET scan, and together with CT scan. Using fluorodeoxyglucose, FDG, to detect occult metastasis. Now we come to the classification of gastric cancer. Okay, the Lauren classification. According to this classification, there are two forms of gastric cancer. Okay, one is known as the intestinal gastric cancer, where there is a polypoid tumors or ulcerative lesion in the mucosa of the stomach, and these are probably areas. These tumors arise in areas of intestinal metaplasia. Then there is the next type, is the diffuse gastric cancer, which infiltrates deeply into the stomach with no obvious mass lesions. It spreads widely in the stomach wall at an early stage, and this is what we call Lionitis plastica. Okay, the next classification is the Japanese classification of early gastric cancer, or EGC. Early gastric cancer is defined as cancer limited to the mucosa and submucosa, with or without lymph node spread. Okay, so it's T1 and any nodal status, any nodal status. Japanese classification is type 1, can be seen in this diagram here, is protruding type. Type 2 is superficial, involving the mucosa of the stomach. And the third one is the exacerbated or cavity type of thing, which involves the wall, the muscular layer of the stomach. Okay, on endoscopy, these are the pictures that you can see. This is the protruding type. You can see here protruding type. And number 2 here is the superficial type. Okay, this is superficial, more ulcerating. And the third type is your exacerbated type, where there are deep ulcers, penetrating to the wall of the muscular wall of the stomach. Then there is the advanced gastric cancer, the classical classification, and this is classified according to the Bowman's classification. The cancer that infiltrating the muscularis layer is called advanced cancer. And according to Bowman's classification, there are 4 types. And the first type is the protruding type here. Can you see? type 1. Type 2 is the ulcerative type here. Okay, type 2 is the ulcerative type. Type 3 is ulcerative and infiltrating. Ulcerative and infiltrating. That is type 3 here. Okay, the superficial ulcer with deep infiltration into the wall. And type 4 is purely or infiltrative. Okay, which is known as the Lymphadenectomy plastica. In fact, type 3 is the early form of Lymphadenectomy plastica, and type 4 is your advanced Lymphadenectomy plastica. And Lymphadenectomy plastica is commonly considered incurable. Now the spread of gastric cancer. The number of ways it spreads, which are important for the spread of gastric cancer. Direct spread through the muscularis, through the serosa, okay, to the wall of the stomach, into the serosa, and then to the adjacent organ. The adjacent organs involve are commonly the pancreas, colon, and liver. These are the adjacent organs. Then you have the lymphatic spread, both by permeation into the lymphatics and embolization into the lymphatics. Then you have the hematogenous spread, usually after it spreads to the lymphatic nodes first and then to the hematogenously into the liver, lung, and bone. These are the common sites of hematogenous metastasis. Another important mechanism of spread for cancer stomach is known as the transperitoneal spread, where the tumor infiltrates the serosa into the peritoneal cavity and spreads along the lining of the peritoneal cavity into the whole abdomen. Classically, this is known as carcinomatosis peritoneal and usually presents with ascites. It's an advanced condition. In case of cancer, the patients are usually very emaciated and they usually have cross ascites, which can be detected by clinical methods. Some of the deposits will be deposited in the Bloomer rectal shelf, and these can be palpable on per-rectal examination. The Bloomer rectal shelf is a rectovesicle or a rectouterine pouch in the patient. Then you have the Krukenberg tumors, which are gastric tumors spreading through the transperitoneal spread to the ovaries. And lastly is the Sister Joseph's nodule at the umbilicus, which is also due to transperitoneal spread to the umbilical region. Okay, these pictures, these are CT scan. These are the gross findings at surgery. Transperitoneal spread. You see multiple nodules scattered all over the peritoneal lining of the intestine. Okay, on CT scan, they can be seen as hyperdense nodules, tiny hyperdense nodules around the lining, in the lining of the peritoneum. Here and here, this is larger nodules which are seen in the peritoneum. And I told you, peritoneal metastasis to the Bloomer shelf. This is the Bloomer shelf that can be detected on digital examination. Okay, the deposits of cancer in this bladder, this is the rectum, so rectovesical space here, this pouch. Okay, this is known as the Bloomer shelf in males. This is a picture to show you the rectovesicle and the rectouterine pouch, where tumor metastases from the peritoneal spread in cancer of the stomach are deposited. Next, we come to the TNM classification. The T status represents the tumor size and penetration. It can be as tumor in situ, TIS, T1, T2, T3, and T4, as all shown in this picture here. T1, when it is involved the lining, the mucosa of the stomach. T2, when it's grown into the muscular wall, okay, the longitudinal muscle, the inner layer of the muscular wall. And T3 is spread through the outer serosa, but it does not cause any infiltrated to any organs here. And tumor, T4 is tumor spread to the other nearby organs. The end, end status is cancer has not spread to the lymph nodes is N1, N2, N3, and N1, N2, N3 are assured. Okay, less than 6 nodes, 7 to 15 nodes, and more than 15 nodes. And M0 and M1 are the classical no metastasis and metastasis. This is a clearer picture of the TNM classification. We have a mucosa here, stage 1 or TIS. Submucosa, involve the submucosa here is stage 1 within the submucosa. Stage 2 has gone to the muscle layer, especially the inner longitudinal layer. And stage 3 has gone to the serosa, but it has not gone outside the serosa yet. And the stage 4, when it has penetrated the serosa into the neighboring organs.
Okay, this slide shows you the different types of lymphadenectomy for gastric cancer. Okay, D1 and D2 here. D1 and D2 involving the N1 and N2 lymph nodes, level 1 and level 2 lymph nodes. Especially the first diagram here, this is for curative early cancer. So you remove lymph nodes 1 to 6, 1 to 6, all the perigastric lymph nodes. Okay, that's lymph 1. D1 lymphadenectomy. D2 lymphadenectomy, you go a bit further. Here, the one encircled in blue here. Okay, this will be lymph nodes 7 to 11, the second tier of lymph nodes here. Okay, D1 and D2 are the most commonly done operation for uh, gastric carcinoma. D3 and D4, especially for D4, when it is periaortic nodes and lymph node 15 and 16 here. Okay, they are more of a palliative resection. And for N3 can be curative as well as palliative. So here, when lymph nodes 12 to 14. Okay, 12 to 14, you can see here 12, 13, 14. These are the clip of lymph nodes. So these are the various types of lymphadenectomy, and the most widely done is D1 and D2 lymphadenectomy. Okay, this is another diagrammatic representation of the various types of surgery, especially lymphadenectomy, gastrectomy, and lymphadenectomy for gastric cancer. D1, the primary tumor in the stomach, perigastric lymph nodes 1 to 6 are removed. So D1 lymphadenectomy, and we are thinking of cure. D2 is when the second tier of lymph nodes, lymph nodes 7 to 12, and this is the D2 lymphadenectomy. Okay, D1 and D2 are for curative resection. D3 is more of palliative, so you remove the D2 plus the D3 lymph nodes. D3 lymph nodes are the para-aortic lymph nodes, and these patients may have to give upfront chemotherapy plus the D3. This is all controversial, very controversial treatment. Sometimes they can have metastatic micro lymph nodes as well. Okay, so you try to remove as much as possible. So this is a D3 lymphadenectomy. And this is when metastases are there, then you may have to give upfront chemotherapy and then decide if you want to do any form of surgery.
Next, we come to the operability of gastric cancer. Before gastric cancer can be operated, it is utmost importance to assess whether it is operable or not. And this can be done by CT scan with possible PET scan and preoperative laparoscopy. In general, the incurability or inoperability is determined by hematogenous spread, especially to the liver, lungs, and bones, involvement of the distant peritoneum, which can be detected by preoperative laparoscopy, N4 nodal disease and disease beyond N4 node. N4 nodal metastasis refers to pre-aortic or hepatic hilar lymph nodes. Fourthly, fixation to structures that cannot be removed, such as aorta, vena cava, and certain cases of pancreas and liver. In operable patients, they should also be subjected to neoadjuvant chemotherapy. In patients who have operable cancer, radical total gastrectomy is the surgery of choice. In this surgery, the aim is to remove the stomach and block, remove the whole stomach and block, including tissues of entire greater omentum around here and the lesser omentum. Resection margins are well clear of tumor more than 5 centimeters. The esophagus is divided, whole stomach is removed. Sometimes distal pancreas was also removed. So here, this is the whole stomach. The esophagus is divided, so is the duodenum, and the whole stomach is removed. And then re-anastomosis is carried out. Two anastomosis, esophago-jejunostomy and jejunal-jejunostomy. Okay, this diagram on the slide here shows you how the continuity is re-established after removal of the whole stomach. Okay, after the esophago-jejunostomy here, it can be either end to end or side to side, and a Roux-en-Y jejunal-jejunostomy. Okay, this is how it is re-established. As for the lymph node removal, in D1 gastrectomy, N1, the first tier of lymph nodes, is removed. And in D2 gastrectomy, the N2 tier is removed. In cases of tumors involving the distal part of the stomach, the proximal part of the stomach, the fundus, is left intact. Only the distal part is removed, and this is known as subtotal gastrectomy. And it is the removal of the stomach is reconstructed with the gastrojejunostomy, and this is known as the Billroth-2 gastrectomy. At times, to prevent the reflux of jejunal contents into the jejunum, a Roux-en-Y loop jejunal-jejunostomy is done in some patients. Now we come to the palliative treatment for inoperable cases. Okay, there are quite a number of them. Carcinoma of stomach is famous for presenting late because of delayed diagnosis. Palliative surgery, gastrojejunostomy or Roux-en-Y anastomosis, gastrostomy sometimes when the tumor is causing blockage, so you can insert a tube into the stomach to decompress the stomach and also act as a feeding gastrostomy. Palliative chemotherapy, the drugs that are used is pirubimazine, cisplatinum and 5-fluorouracil. Palliative radiotherapy, especially for painful, bony or local metastasis which cannot be resected. These days, immunotherapy has become also important, use of monoclonal antibodies. Okay, trastuzumab or Herceptin has become an important drug in immunotherapy because some of these cancer cells are HER2 positive and they respond to Herceptin treatment. Finally, we come to the prognosis of gastric cancer. Again, as like in all malignancies, it depends on the stage of diagnosis. The 5-year survival rate depends on the stage of diagnosis. Overall, it comes to about 70%. Okay, if you diagnose early and treat, you can get 70%. In stage 1, it can be as high as 90%. Stage 2, as high as 70%, stage 3 around 50% or so, and stage 4 is low, less than 10%. Okay, so the degree, as I told you, the TNM classification, the stage of the disease determines the 5-year survival rate.